All right, well, I'm going to talk about periprosthetic proximal femur fractures. So that's not advancing. Oops. In any event, so if you look at these injuries, they have a significant burden of illness. There's an increasing prevalence of these injuries, growing elder population. They're very akin to hip fractures. They have a high mortality rate, high complication rate. Some of the complications are related to limited weight bearing, and it's really important when you're managing these patients to optimize medical and fracture management to allow early weight bearing. So I think just like with a hip fracture, medical management is key. You want multidisciplinary orthogeriatric care, rapid medical optimization. You want to reduce the delays to surgery, optimize fluid management, prevent delirium. And I think whatever you do, you want to get the patient weight bearing as tolerated post-operatively. And you can see actually, if you look at what people are actually doing with these, very few people actually get patients fully weight bearing. So for example, in this study of European hip surgeons, only 5 to 49% of the surgeons actually allowed full weight bearing after fixation of a typical proximal periprosthetic femur fracture. So why is restricted weight bearing used? It's often used to compensate for poor mechanics, poor fixation, poor bone, and poor patient compliance. So you've got to be thinking of those things and what you can do to mitigate. So for example, this is a patient who had a total hip stem and varus. There was a perforation at the tip of the stem. Patient had a periprosthetic fracture. Patient was plated with a single plate. It broke. Rather than sort of considering that the stem was in some varus, it was just replated and broke again. So patient was restricted in terms of weight bearing throughout management, and that's really not the solution to this problem. So when a failure occurs, you really got to think through the reasons as to why that occurred and not use restricted weight bearing as your solution to the problem. So in terms of failure mechanism, poor mechanics are a common problem. Mechanisms can be both with implant failure and fracture fixation failure, and also inadequate diagnosis. So if you look at patients assumed to have a B1 fracture, about 20% will actually be loose at the time of surgery and will actually, in fact, be B2s. I think it's really important to work the patient up properly before surgery, talk to the patient, find out if they were having any symptoms, look at pre-injury radiographs, compare them to previous radiographs. CT scanning with metal artifact reduction can sometimes be helpful. And then intraoperatively, you want to determine whether you're actually going to assess the prosthesis at the fracture site or do an arthrotomy and dislocate the hip to actually check for prosthesis stability. If the stem is loose, you should have the capacity potentially to do a revision. So in terms of treatment options, they would include fix the fracture and revise, or do a complex reconstruction. I think whatever you're going to do, you want to allow early weight bearing. So if you think that after fixing the fracture, weight bearing is not going to be possible, then you should think of a different treatment option. So typically for B1 fractures where the stem is well fixed, you're going to do open reduction internal fixation. That typically is with a locking plate, plus or minus a second plate or allograft. Small percentage of patients, you can consider a revision. I think the main controversy with B1 fixation is centered around the use of isolated lateral lock plating or biplanar fixation. This is just an example of a lateral lock plate with proximal screws and cables versus biplanar fixation with a lateral locking plate and an anterior allograft strut. So I think the questions that you would ask is, what is the ideal plate fixation construct? What's the role of biplanar fixation versus single plane fixation? Role of bicortical versus unicortical fixation, and role of cables. Problem is, if you look at the literature, much of the current evidence is biomechanical, and we can't tease out the answer to these individual questions from clinical series. I think what's pretty clear from the literature, biomechanically certainly, and I think to a lesser degree clinically, is that biplanar fixation probably gives you the best mechanical construct. I think if you look at what the evidence is around the mechanics of fixation, biplanar dual fixation results in improved fixation stability and the best biomechanics. Bicortical fixation, if you get it with a single uniplanar plate, doesn't eliminate the advantages of 90-90 fixation. If you are going to use a single locking plate, you want to try and get bicortical fixation. So unicortical fixation in and of itself is usually not adequate in poor quality bone. And for proximal fixation, which is the challenge, you want to have at least 4 points of good fixation, and the fixation along the femur should be spaced. So use a long plate if you can, as opposed to a shorter plate. The question is biplanar fixation always necessary? And I think when you're thinking that through, you've got to consider a number of patient factors. So patient age, bone quality, fracture pattern, implant type, comorbidities, and previous surgery. So this is a patient who had total hip replacement, was doing squats with weights about 2 months post-op, and had a periprosthetic fracture. Implant was stable. Fracture at the tip of the stem. We did an MIS lateral lock plate, and this is the x-ray in the middle at around 2.5 months, and the patient went on to heal completely, uneventfully. This is a patient who had a nail and had arthritis, had it removed, converted to this monoblock diaphyseal fixation stem, had a undisplaced fracture at the tip of the stem. So this patient couldn't tolerate the pain that they were having, wouldn't mobilize. So basically took the patient in the operating room, again did a MIS plate, and fracture was went on to heal uneventfully. So I think if you're going to do MIS, if you're going to do a single lateral lock plate, I think results are better if you can do it MIS. Less OR time, less blood loss. The patients tend typically to do better. I think if you're kind of thinking through who should get a single lateral lock plate versus biplanar fixation, you want to use more fixation when fractures are slow to heal and early weight bearing is going to be problematic. So just listed some examples where that's the case. So large canal filling stems, particularly in association with transverse or short oblique fractures, where you have no medial contact. And that is a critical factor because you're putting a plate on the lateral side, that plate is being cycled, and then typically the plate breaks if you don't have medial contact. Obesity and atypical fractures. So this is just an example of that. The patient with a very large diaphyseal fixation stem, short oblique fracture. Patient has an atypical fracture. You can see the beaking at the fracture site. This patient was treated with a periprosthetic plate and spaced fixation, and you can see the gap on the medial side. So about 4 months post-op, this plate broke right where the screw holes in the plate were. I think if you look at the literature, you can see very clearly that usage of uniplanar fixation is associated with fairly high complication rates. So for example, this series from authors that know what they're doing, 2-year probability of any reoperation, 19%, and they actually recommended for B1 fractures augmenting fixation with orthogonal plating. This is just an example of that. A 75-year-old lady with osteoporosis has an interprosthetic fracture. You can see impending atypical bump there distally at the cement plug. Patient goes on to develop a transverse fracture. This is going to take a while to heal. So this is, we treated with a laterally based plate and an allograft strut, and this patient went on to heal uneventfully. This technique is also very useful to salvage cases where you're worried about bone stock. So this is a patient who was treated with a single plate. You can see lots of fixation right at the fracture site, unfortunately, cerclage wires disrupting the biology of fracture healing. This patient went on to a delay in healing, plate broke, and was salvaged with a laterally based plate, spaced fixation, and an anterior cortical strut, and went on to heal. If you look at clinical outcomes for biplanar fixation against lateral plating, there's very few comparative series, but the results seem to be better in terms of failures with biplanar fixation. I think what is a controversy is whether or not you should use a strut versus a second plate. and those techniques have their advantages and disadvantages. It does seem to be, though, that with 90-90 fixation, you're going to get earlier weight bearing. And again, this is a follow-up series from HSS, where they actually looked at dual plate fixation in follow-up to their previous paper, and they reduced their failure rate from 19% to 8% with an average follow-up of 2 years, and got the patient's weight bearing as tolerated much earlier. We're actually doing an OTA funded randomized controlled trial to address this issue and try and get some evidence in this area. I think the other thing to also keep in mind is that these fractures sometimes would benefit from revision. So it's really easy to take out the stem, then I'll do a revision. The thinking being that that's kind of like converting to an IM nail. The stem's well fixed, then I'll do open reduction internal fixation. B2s where the stem is loose, the typical gold standard these days would be revision with a long titanium fluted tapered stem. I think the role of struts in 2024 is much reduced compared to what it was previously. I think if you're going to fix one of these, you want to work through the fracture. You want to use a prophylactic cable on the distal segment, prepare the distal segment, pot the implant, and then basically fix the fracture, usually with cerclage. You usually don't need to apply a strut as is shown here. This just shows a case, a B2 fracture, the stem is loose, comminuted fracture. Basically extract the stem, use a modular tapered titanium fluted stem, pot it distally, fix it proximally with cables, and you can allow the patient to immediately weight bear. So in conclusion, the keys to success that allow early weight bearing are to optimize medical management, so you don't want a patient lying in bed with delirium. Revision arthroplasty does play an important role for B2 fractures. The best mechanics are with dual fixation, but you don't need dual fixation in every case. I think biplanar fixation, so 90-90 fixation, is ideal when you have a large canal-filling stem, a transverse or short oblique fracture, no medial contact, and obesity. You want to optimize proximal fixation with at least 4 points of fixation. Screws in general are better than cables, and you want bicortical fixation ideally. And you want to follow these principles to allow early weight bearing. Thanks very much.